had Chiari malformation, but Dr. Tiziana Granata, she's a child neuropsychiatrist, will shed light on this different definition that she opted for.
Grazie intanto.
I don't know if I will. Anyway, good afternoon, and thank you for inviting me here. I will start off by saying that this is a minor problem in Chiari patients. I will start by showing a literature review. There isn't much evidence in the literature. The literature is quite recent as well, but I think it shows well what is then also found in daily clinical experience, that is differential diagnosis problems and pathogenetic mechanisms that underlie epilepsy in these patients and their association with different neurological signs. The literature has been very scant until the 1990s, and this is probably due to the progressive recognition of Chiari malformation with few symptoms, where epilepsy was sometimes the symptom that led to the performance of radiological examinations and the identification of Chiari's malformation. The first paper is a 1997 paper that was issued in Child Neurology. 11 patients were evaluated by means of MRI who had seizures, developmental motor language delay, and autistic-like behavior. Out of 11 patients with neurological signs, 6 had epilepsy. I would like you to note that almost all of these patients, except the last one, also had other related neurological signs, namely developmental delay, motor delay, and associated autism. The author's conclusion was that in these patients, Chiari malformation was not a random finding, but was rather the marker of a development problem. Most notably, one of these patients had agenesis of the corpus callosum, which pointed to an abnormal development. The authors hoped that in future the presence of cortical malformations that could not be identified by magnetic resonance imaging in those years would be identified. That would also explain delay and seizures. Some years later, a paper was published. It was a multicentric study involving patients in 4 different Italian centers. There was a bias, however, because those were epilepsy centers. So there was a recruitment bias involved in this study. These 4 centers included 10 patients with Chiari malformation and who were referred because of behavioral disorders or seizures. 7 in 10 of these patients had seizures, and 2 in 3 patients didn't have seizures but had EEG abnormalities. The authors highlighted that in more than one case there was a related mild or moderate mental delay. Seizures were mainly partial but also secondary, and interestingly, the great majority of seizures was well controlled by treatment, and treatment led to a significant reduction in the number of seizures. The authors also stated that even though this recruitment bias didn't give any epidemiological value to their data, epilepsy seemed was an occasional finding. They also noted that epilepsy outcome is benign in the majority of patients. Once again, they assumed the presence of microdysgenesias of the brain, which, however, could not be demonstrated at the time, but they were not demonstrated later either, and a possible role of the cerebellum in the triggering off of crisis. This is a paper published by a Bologna group on all patients with posterior fossa anomalies and seizures, and the group of anomalies that was most frequent was the cerebellar hypoplasia in these 54 patients. Arnold-Chiari malformation was quite significantly accounted for here, and epilepsy was most frequent. These authors, too, stated that there must be some underlying mechanism in these patients, even though a genetic role might be present in epilepsy and might be explaining epilepsy, and they also stated that in a relevant number of patients the outcome was positive. A more interesting and recent study, which was also mentioned by Dr. Saletti this morning, was issued by the Siena group. It's a multi-center study, and it is based on 4 neuroradiologic centers. 35 patients with Chiari malformation were reviewed, and symptoms, neurological symptoms such as mental delay and epilepsy were found in 9 patients. More specifically, 5 patients had seizures, and some more had EEG anomalies but no seizures. Rather than look for a possible cause-effect relationship with Chiari malformation, the authors assumed that Chiari malformation associated to mental delay and epilepsy might be a well-defined and specific syndrome. Now I'm going to briefly outline our evidence. Dr. Valentini sampled 99 patients with Chiari malformation, so this is a rather important number of patients, and 6 of them experienced seizures. So our case series 2 confirms the low incidence of epilepsy in Chiari type 1 malformation. Looking at the details of these patients, those circled in red are those patients in whom Chiari malformation was found through a radiological analysis, because these patients had had seizures. This doesn't mean that their seizures were due to Chiari malformation, but this is why they were referred for neuroradiological evaluation. More importantly, these were patients whose epilepsy had a different cause. One child was a little girl who had had a cranial trauma, with the posterior encephalic cyst at 5 months. Subsequently, she had focal seizures that were consistent with the site of injury. Then at least 3 patients, well, one patient had Prader-Willi syndrome with congenital hydrocephalus. Other patients had somatic features and minor dysmorphisms with associated mental delay and autism, which point to a complex syndromic picture that also includes chiari malformation. Interestingly, in one of these patients, a complex deletion was observed through microarray CGH tests. These patients also had a positive outcome. In 2 cases, there were just seizures during sleep. All these patients are free from seizures. These patients are free from seizures, and they're seizure-free without being under treatment, and they have been so for the last 2 years. I always think that when there are symptoms such as mental delay and epilepsy, chiari malformation is part of a complex syndrome which probably have a misdevelopment genetic base. Radiographical data in our epileptic patients never show the features of injury-related epilepsy. For those who are familiar with EEG, in this EEG, in this 11-year-old female patient, there are 2 patterns which are found in forms of epilepsy that have a genetic base. That is asynchronous centrotemporal anomalies with a functional form or idiopathic form pattern, and widespread anomalies which are typical of idiopathic form. This is the typical EEG that is found in genetically determined syndromic features. This was a young boy with autistic signs. He had just 1 seizure. He didn't undergo any treatment, and since 2000 he hasn't had any seizures during sleep or while awake. Here we see focal patterns, focal anomalies, and these focal anomalies were maintained with the same features also years after the seizures, and this is reminiscent of functional childhood forms of epilepsy. We were so engrossed that we don't know how much time available you have still. I am told it's 6 minutes. So I would like to describe a paper published by Dr. Iannetti from Rome, who carried out a SPECT study in 4 children with epilepsy, showing the presence of occipital hyperfusion, which seems to correspond with EEG anomalies, and hypoperfusion in the cerebellum. The authors assume that cortical hyperfusion may be related to dyskinesia, whereas cerebellar hypoperfusion could be related to a structural deformation of the cerebellum. But, however, this is just an assumption and still needs to be verified. The questions are the seizures that are cerebellar in origin? Is the cerebellum involved in mechanisms actively terminating or determining seizures? Is cerebellar syndrome related to seizures? Well, these questions haven't been answered since Jackson's time yet. Jackson studied patients with cerebellar epilepsy. Studies followed assuming that there could be no seizures that were of cerebellar origin. Then in 1920, the so-called cerebellar fits were described, which are decerebration-related rigidity episodes, and there's also evidence of focal crisis, which have been documented by EEG in a patient with cerebellar gangliomas. The possibility that the cerebellum may play an inhibitory function on the triggering of seizures, that is the assumption of a structural anomaly of the cerebellum with less inhibition that may favor excitatory mechanisms, hasn't been confirmed, even though experimental data have been provided in the past as to the fact that the cerebellum could induce epileptiform activity in the hippocampus. Other interesting data involving cerebellar stimulators were provided, even though there was no follow-up to this, because they didn't prove that cerebellar stimulation could significantly affect reduction in crisis. The last point I'd like to make is differential diagnosis, because there are some symptoms which may be mistaken for epilepsy. They are syncope-associated phenomena, and most importantly, cerebellar fits. It is known that in Chiari malformation, syncope can be associated, so differential diagnosis is not so complicated. It is more complicated, however, especially in infants, to differentiate cerebellar fits from epilepsy. The most recent study that has been published in this respect involves 13 patients. It was actually carried out on 47 patients who had undergone surgery for Chiari malformation. 13 of them had paroxysmal episodes that were classified by the authors as cerebellar fits, but the authors highlighted that before correct diagnosis was issued, as many as 9 out of 13 had been evaluated for epilepsy or cardiogenic syncope episodes. As for cerebellar fits, they are drop attacks with or without loss of consciousness, which are associated to abnormal extensor posturing, and they may be associated to respiratory insufficiency, respiratory failure. This is a picture from a patient who had several cerebellar fits that disappeared after Chiari malformation decompression, and this is Jackson's own drawing. Jackson drew a child who is undergoing a cerebellar fit. The final paroxysmal episode that I'd like to highlight to you is the so-called paroxysmal dyskinesias in Chiari malformation children. This is a case series issued by Dr. Angelini, Zorzi, and so on, all members of our group, regarding patients, children with such dyskinesias. They were all idiopathic and only one of them had Chiari malformation. What the cause-effect relationship may be, I cannot tell you, but I can tell you that a paroxysmal episode in a Chiari malformation child is and can be different to an epileptic seizure. Last but not least, I'd like to note that EEG abnormalities without epilepsy can be observed in Chiari malformation patients. This paper shows IRGA activity in 2 patients. Here there's also a peak episode, but this patient also suffered from epilepsy, and all of this disappeared after surgery. It was probably the consequence of an altered CSF flow. So this activity is related to an alteration of subtentorial structures, that is, cerebellum and brain stem. So as a conclusion, epilepsy is a rare symptom in Chiari malformation and the prognosis is usually good. Seizures are mostly observed in the context of syndromes that also include mental retardation, autism, somatic dysmorphisms. Differential diagnosis must include cerebellar fits, syncopes and paroxysmal movement disorders, but EEG abnormalities, regardless of whether seizures are present or not, can be epileptic or related to slow activity, and the clinical context should be evaluated in order to establish which is which. There is no definite evidence for a role of Chiari malformation in epilepsy. And electroclinical features of epilepsy, a good outcome in many cases. The finding of age-related pictures and the frequent association with other developmental symptoms, such as mental retardation and language development delay, suggest that within the broad group of Chiari malformations, there may be a subgroup in which Chiari's malformation is a part of a more widespread developmental disorder. Thank you. Thank you, Tiziana. Microphone, please. I found this contribution very interesting because it outlined very well the relationship between epilepsy and Chiari's malformation, and also because it highlighted unusual symptoms that should be taken into account. So I think that this contribution deserves to be praised because it highlighted these syndromes which have a diagnostic value. I'd like to share with you my own experience. I'd like to know whether others had the same experience. A few years ago, I was dealing with dystonias. An 8-year-old girl came to our observation with a suspect axis dystonia, but it wasn't axis dystonia. It was neck pain, which we correlated with an asymmetric tonsil descent in a Chiari-1 syndrome. Any comments? Theoretically, this could be similar to trigeminal neuralgia and face pain, all those symptoms which are related to abnormalities in the posterior fossa.